today's lecture on the management of children with complex urologic conditions who also have chronic kidney disease. My name is Zachary Corrigan. I'm a Senior Director at the Children's Hospital of Philadelphia. Before we start, I just want to cover a few housekeeping items. One, this lecture is being recorded. A copy of the recording will be shared with all registrants and attendees. Second, the lecture has been accredited by the Children's Hospital of Philadelphia for one AMA PRA Category 1 credit. At the conclusion of the lecture, we'll share a link with a brief survey that folks can fill out to claim their credit. Lastly, if you have questions that you'd like to ask, we encourage them. Please use the chat feature to place your questions into the chat queue. When we get to Q&A, we will go through all of the questions. You do not need to wait until the Q&A section in order to ask your question. Now I'll introduce our two speakers today. Benjamin Laskin is an attending physician in the Division of Urology and Medical Director of the Kidney Transplant and Dialysis Program. Dr. Laskin's research interests include infections and kidney disease in immunosuppressed children, including those who've received a bone marrow or solid organ transplant. He's an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dana Weiss is an attending physician, a pediatrician, attending pediatric urologist in the Division of Urology at the Children's Hospital of Philadelphia, an assistant professor of urology and surgery at the Perelman School of Medicine at the University of Pennsylvania. Dr. Weiss's research is focused on several areas, including bladder exstrophy and neurogenic bladder, among other projects. She's involved in research with the Multi-Institutional Bladder Exstrophy Consortium. I'll turn it over to our speakers.
Thank you very much for joining us this morning. I'm Ben Laskin. I'm a nephrologist at CHOP, as Zach mentioned, and I'm joined by Dana Weiss, who is a urologist at CHOP. And we're going to talk about management of children with complex urological disease from chronic kidney disease through transplant. Neither Dana nor I have any disclosures. So we have three objectives for you today. First, to explain the conservative management of children with chronic kidney disease who also have complex anomalies of the urinary tract, focusing mostly on the urological management of these children. Review the surgical management of children with complex urological and kidney disease, especially in preparation for transplant. We're going to present three cases to demonstrate the pathway from chronic kidney disease to transplant in children with complex urological disease. We picked these three cases. They're all infants who we started seeing early in life, progressed to chronic kidney disease and needed dialysis very early on in life, and then eventually all have received a transplant between the ages of 3 and 5 years. Our goal is to spend about 10 to 15 minutes on each case. Dana and I are going to go back and forth in terms of the clinical presentation and then some specific take-home points for each case, and then hopefully we'll have about 15 to 20 minutes at the end for any discussion or questions. So case number one. So this was a 26-day-old male who was admitted for anuria and lethargy. Prenatally, the mom had noted a low amniotic fluid index throughout pregnancy, which dropped off during the last week of gestation. After birth, he was noted to have bilateral non-palpable testes. Presented to the emergency room with lethargy, and a septic workup was initiated. His creatinine on presentation was impressive, 9.4, with hyperkalemia, acidosis, and some hyponatremia. Given the extreme electrolyte abnormalities, we started on acute peritoneal dialysis. And ultrasound evaluation that you can see here showed dysplastic kidneys, echogenic kidneys, no signs of hydronephrosis or obstruction on ultrasound. Not surprisingly, with a creatinine of 9 this early in life, the patient remained anuric throughout admission. Was eventually discharged home on maintenance peritoneal dialysis for end-stage kidney disease. And then the patient underwent genetic evaluation, and this was done incidentally almost, a whole exome screening was performed in the hospital because the patient had some other comorbidities, including cardiovascular disease. And as a result of this exome, it was incidentally noted that the patient had a WT1 mutation. So the constellation of symptoms were consistent with dentist rash. And so it's important in patients with WT1 mutation to understand the risk of gonadoblastoma or Wilms tumor in these patients. And so oftentimes they need either screening serial ultrasounds or perhaps bilateral nephrectomy. So these were the questions that came up in this patient. Given, of course, the end-stage kidney disease, the anuria, was already on peritoneal dialysis, the risk of malignancy with the WT1 mutation, the decision was made to eventually go forward with bilateral nephrectomies. Just a little bit more information before I hand it over to Dana for this case. At 1 year of age, the patient underwent bilateral laparoscopic nephrectomies. This was done retroperitoneally and also had repair of his undescended testicles. The OR duration was 6 hours, so a long procedure. It was done laparoscopically, so not much blood loss. And then, not surprisingly, on pathology, the kidneys show congenital renal dysplasia with nephrogenic blastema, consistent with the dentist rash syndrome. Importantly, he received only one hemodialysis treatment after surgery. So despite having pretty extensive abdominal surgery, although it was done laparoscopically, he was able to return to low-volume peritoneal dialysis fairly quickly. So as many of you know, the decision to do surgery on these children, whether they need minor surgery like hernia repair, which we'll talk about in some of our other patients, or more extensive surgery, either due to nephrectomies or unfortunately in some cases bowel issues in other patients, and we often struggle with how long we should keep them off of peritoneal dialysis. And patients this young of age are very challenging to dialyze with hemodialysis. And so I'm going to turn it over to Dr. Weiss, and she's going to talk a little bit about the literature and our approach to getting these kids back on peritoneal dialysis as quickly as possible after abdominal surgery to avoid hemodialysis.
Good morning. Yeah, I agree. You know, there's always been concern over when you start peritoneal dialysis after any transperitoneal surgery, if you're going to be doing a transperitoneal nephrectomy or even laparoscopic orchipex or even hernia repair. People have looked at this, but there's no sort of great data as all of the series are quite small, and many just have sort of anecdotal evidence. One series, again, only very small, and 3 patients showed no adverse events starting 10 to 14 days after a large intraperitoneal surgery. And another series even reported restarting peritoneal dialysis as soon as 5 days as being safe. The use of retroperitoneoscopic nephrectomies, as was done for this child, has been reported to be safe and allow very early return to peritoneal dialysis. Within in this one report out of Indiana, within 9 hours, within obtaining a max fill at 60 hours. And as Ben mentioned, this patient was able to only receive one hemodialysis treatment, then went back on peritoneal dialysis, and that was after a intraperitoneal laparoscopic orchiopexy, as well as the retroperitoneoscopic nephrectomies. So overall, it seems like early return to peritoneal dialysis seems safe. I think that people have to weigh the sort of balance the ability to do retroperitoneoscopic nephrectomies because it's something that's not as frequently done. And if it's going to be a higher risk surgery because it's not as frequently done, then you might weigh, well, we can do an open transperitoneal laparoscopic nephrectomy and be able to return maybe even as soon as 5 days to peritoneal dialysis, or you can do an open retroperitoneal nephrectomy. But at least if you're going to be doing a orchiopexy or something like that, that's even a slightly smaller opening in the peritoneum, you can have very early return to peritoneal dialysis.
So some follow-up information on our first case. So 2 years after a nephrectomy, completed his stage orchiopexy. It was growing well on peritoneal dialysis, reached 10 kilos or greater than 10 kilos, which is our center's cutoff for starting to consider them for a transplant. Unfortunately, it was noted, given his history, that he had a very small capacity bladder on cystogram, less than 10 mLs. And so the next set of questions that arise in the management of this patient were to proceed with transplantation, given his small bladder, to consider bladder augmentation and creation of a catheterizable channel, either prior to transplant or transplanting him and considering this down the road as you get older, or to consider a novel method for bladder cycling, which Dana will go into now.
This case also, again, we chose these cases to highlight some of these different decision points in the management of these patients. The concept of transplanting to a small bladder causes a lot of concern, and that could be a small bladder due to bladder outlet obstruction, like ludo and utero, absent kidneys due to a vascular insult or nephrectomy, and so the bladder hasn't been exposed to urine, or bilateral ectopic ureters. The concern has led people to even proceed with augmentation prior to transplant in order to ready the bladder to receive this new kidney. However, even historically, there have been several series that report how the bladder can normalize after transplant without doing anything at all. In an early series from 1976, Casey Furlett had shown 5 patients with valves who had small bladders. Now, depending on their age, 100 milliliters is not necessarily small, but in an adult it would be small. And they all normalized after transplant regarding their bladder size. Later series shows, they're all small series, showed that patients with valves, they were able to compare those who did not have an augment with those who did, and all the ones who did not have an augment prior to transplant had an increase in their bladder capacity and actually never needed to end up going on to augmentation, with no difference in their sharing of creatinines after their transplant. And finally, another series showed a massive increase in the volume from 14.5% EBC pre-transplant to 84% EBC post-transplant, again, all without doing anything at all to the bladder. In light of this, that bladders can increase in time over transplant after transplant alone, the concept of aiding bladder growth prior to transplant might aid for early post-op function has come up. It's an older series that demonstrated 5 adult males with defunctionalized bladders from various conditions who underwent even only brief cycling by placing a suprapubic tube or urethral catheter into the bladder, and were able to have, again, significant increase in bladder capacity from as low as 30 cc's to up to 350 cc's after transplant, and that was only after very brief cycling. So considering this background, that we know that small bladders can grow over time after transplant, even without an augmentation or even without doing anything at all, and that cycling can assist the bladder to grow ahead of transplant if there's any concern for how it's going to function in the immediate postoperative period. There's this concept of a gentle increase, gentle bladder cycling to increase the bladder capacity over time. And so the method that we have been using at CHOP has been to place a suprapubic tube under direct vision in the operating room. I'm just going to play a little video while I continue here of the cystoscopy and the placement of tube into this very, very small bladder. And then you leave a constant pressure of about 20 centimeters of water on the bladder. And you do this by mounting irrigation bags to the suprapubic tube and leaving them so that the meniscus stays at about 20 centimeters above the bladder. And I'll show you that we can even aid mobility for these children as they have this continuous bladder cycling day and night, as many hours of the day as possible. Then for surveillance, they undergo ultrasound and suprapubic tube change every 2 to 3 months to assess how they're growing and to make sure they have a new tube. And so this is the little backpack that the kids can wear so that they can go about their day and not just be subject to laying in bed all the day. So we reviewed, this is the last 5 patients, but I believe there's been one more since this. 4 out of 5 had been recommended to undergo bladder augmentation prior to transplant at another center. 4 of them were able to have the percutaneous cystostomy tube placed, but 1 required an open placement in the operating room at the time of that they went for the SP tube placement. None of them had any UTIs or unintended return to the OR other than the routine SP tube change. And we found that their bladder volume increased consistently after a range of between 3 and 8 months of cycling. You can see here that there's a various etiology of their end-stage renal disease, from mostly cystic dysplasia or bilateral renal agenesis, and their bladders were between 5 and 8 cc's at the time that they were started. Just to highlight in our patient, before Ben finishes this case, our patient underwent cycling for a longer amount of time, but had a bladder capacity that reached almost 250 cc's after the cycling of up to 8 months.
So at 3 years of age, our patient underwent an uncomplicated living-related kidney transplant, was voiding every 4 hours. A stent was inserted and removed after surgery, which is typical in a lot of our patients, and at most recent follow-up had essentially normal kidney function, mostly 0.4 milligrams per deciliter of creatinine and a normal ultrasound. So finishing up case number 1 to summarize the renal and urological management of this patient, both surgical and non-surgical. So consider genetic testing in children with early onset end-stage kidney disease, especially in this patient with undescended testicles, in this case, found out that had WT1 mutation requiring nephrectomy to prevent future malignancy. Low volume peritoneal dialysis can be considered in children after undergoing abdominal surgery to avoid prolonged hemodialysis, which is a management challenge in younger babies. And then, as Dana just went through, bladder cycling may be a conservative approach in the management of children with small capacity bladders that need to receive a kidney transplant in the hopes of avoiding bladder augmentation, which itself is associated with complications down the road. So we'll switch gears here and go on to case number 2. So again, we have a baby for you. A 2-day-old male was transferred from an outside hospital for management of elevated creatinine. Prenatal ultrasound showed oligohydramnios and hydronephrosis. The patient presented with a creatinine of 3.1 milligrams per deciliter, mild hyperkalemia and hyponatremia. In this case, the patient had renal cystic dysplasia, so small cysts on the kidney, small echogenic kidneys. Not surprisingly, given the oligohydramnios, there were some respiratory issues immediately after birth. The patient had bilateral pneumothoraces, and then eventually underwent cystoscopy, which revealed a congenital urethral stricture. The patient was maintained and managed medically for the first few months of life, so did not need acute dialysis immediately, but eventually was started on maintenance peritoneal dialysis at 2 months of age for a continued rise in creatinine and trouble growing.
This is a little bit of a bait and switch, as the slide says posterior urethral valves, and we just mentioned that this patient had a congenital urethral stricture. However, even though they're slightly different entities, they function very similarly and really are treated in a very similar way and can have the same sequela. So I just did want to take this opportunity to go over posterior urethral valves, which is the more common source of lower urinary tract obstruction. Classic findings, and you can have this in both cases, is antenatally bilateral renal dilatation, thickened bladder wall, that you can see here, dilated prostatic urethra, giving that classic keyhole sign, decreased renal echogenicity, and oligohydramnios, as this one had. So in valves, all that obstruction, all that problem is caused by this abnormal leaflet that's located just distal to the vira montanum. It's usually based at the 12 o'clock position and radiates inferiorly. And this small leaflet can cause significant sequelae, including renal cysts, renal dysplasia, ureteral dilatation and ureteral thickening, hypertrophied bladder wall, bladder neck, and dilated posterior urethra, and ultimately end-stage kidney disease or even non-survival. So, as was with this child, the initial management, of course, is stabilization from a pulmonary standpoint. Sorry, Ben. Do you want to go into this?
Oh, no, that's okay. So, as I mentioned, the patient had bilateral pneumothoraces. So oftentimes in these babies, we have the NICU team involved in the prenatal consults. For these patients, we in nephrology and urology also see them prenatally and have a frank conversation with the family that in the first few days of life, the most important thing are not the kidneys and not the bladder. Yes, we'll be there. Yes, we'll meet you. But certainly the lungs and how they're doing are the most important in the early stages of life. As Dana mentioned, sometimes these kids don't survive due to their pulmonary disease. We've had patients that have needed pretty significant respiratory support, not surprisingly, oscillator, chest tubes, and things like that. And then oftentimes the patients will survive that initial period, and then, of course, they become ours to manage from a dialysis standpoint and from a urological standpoint. So careful attention to serum electrolytes is important after they are in the pulmonary recovery stages or pulmonary stabilization stages, especially hyperkalemia. Measuring them at least once a day is important. Of course, understanding serum creatinine is an important marker of kidney disease, but if these kids are making urine and their electrolytes are otherwise okay, managing them conservatively off of dialysis is important. So, of course, in the first few days of life, the serum creatinine can be elevated due to maternal creatinine, so trending that over time. And then there has been some evidence in the literature about long-term what their creatinine reaches at 1 year of age, that certainly if it's over 1, over 2, by 1 year of age, the likelihood that they're going to need dialysis or a transplant in childhood is fairly high. And a lot of our patients that have peak creatinines that then nadir under 1 milligram per deciliter by 1 year of age, oftentimes will make it through that high growth period in the neonatal period, and we watch them, of course, closely during adolescence. And a lot of patients reach adolescence and reach the transition point between pediatric and adulthood where they don't need dialysis or a transplant and just get followed over time for chronic kidney disease. So certainly involving urology, nephrology, and the NICU early on in these kids is important, both for their short-term care and, of course, discussion of their long-term outcomes.
So after, as Ben went through all the initial evaluation and stabilization, the initial renal assessment is with an ultrasound, a renal and bladder ultrasound, looking at the renal parenchyma, really looking at the corticomedullary differentiation, parenchymal echogenicity, thickness of the parenchyma to understand sort of what kind of kidney function you might hope from these kidneys, although it's not totally predictive. Severity of the hydroureteral nephrosis, and presence of perinephric urinoma or urinary ascites, which can be present from high level obstruction, and the bladder wall thickness. Early management from the urologic standpoint is urinary catheter drainage. Usually this is done with a feeding tube, a straight catheter, or even if needed, a coude catheter due to the very elevated and hypertrophied bladder neck. One of the things that I always insist on, I don't know if everyone does, is confirming placement of the catheter, because you can have sort of a false return of fluid if you're in the bladder neck, but you're not quite into the bladder itself. So it's helpful sometimes under ultrasound guidance to confirm placement. And also we avoid catheters with a balloon, like a Foley, as that with such a high bladder neck, small bladder, the UOs are very near, and the balloon, even a 1.5 cc balloon, can obstruct the ureters, and you're trying to obtain maximal drainage. And of course, after the catheter placement, you're monitoring for a post-obstructive diuresis as you're monitoring the electrolytes. Then the VCUG will define anatomy of the bladder, bladder neck, and urethra. You see, these are just some characteristic pictures of valves. You can see the trabeculated bladder with diverticula in many of them. Most of them, greater than 50%, will have vesicoureteral reflux at the time of diagnosis. You can see the proximal urethral dilation and elongation, which is one of the hallmarks of valves, and a prominent bladder neck. You can see the demarcation here. Now, as I said, this was a bait and switch because our patient did not have a true valve but had a congenital urethral stricture. And it was a much more subtle finding here, although they can look more like a true valve. And we have seen one more recently that had the much more dilated posterior urethra. But this on cystoscopy, and this is our patient here, you can see this narrowing, and the rest of the bladder and the reflux is the same. This is another patient with a very, very tight congenital urethral stricture, actually had a very opposite outcome and did perfectly well and has not had significant renal compromise despite that. So as far as the initial surgical management of valves and congenital urethral strictures are really managed just the same way. We start with a valve ablation. I would say in this area, valve ablation is the standard of care, but if not, we'll go on to other options. In size, the valve usually have, at 12 o'clock and 5 and 7 o'clock. Some people advocate for just 12 o'clock or just 5 and 7. You can do all of them. I think that you want to be in there just once. You can use a resectoscope or a cold knife, which there's resectoscope is the largest, 9.5 French. It's often hard to get into these newborns. Or you can do the smallest pediatric cystoscope, which is only 7.5 French, with a wire bug B electrode, or some people use a laser. We also advocate for circumcision at the time because it'll reduce the risk of UTI, which can be very significant for these babies who already are fighting for every nephron, every renal function, bit of renal function they can. And complications of valve ablation include incomplete ablation, stricture, urethral stricture that can be noted early on or down the line, and bleeding.
So to give you an update on our second case, so at 1 year of age, underwent left orchiopexy for palpable testes and bilateral inguinal hernia repair. Again, was continued on peritoneal dialysis without the need to switch to hemodialysis. At 2 years of age, underwent video urodynamic studies, or VUDs, which demonstrated a compliant bladder that filled to just under half of the expected bladder capacity, was maintained on Bactrim prophylaxis, and continued on peritoneal dialysis while active on the transplant list. Eventually, at 3 years of age, received a deceased donor kidney transplant, and his most recent creatinine is normal at 0.3 milligrams per deciliter. So to finish up case number 2, I will turn it over to Dana to talk about a little bit more detail on VUDs.
This is one of my favorite topics, VUDs. This is the example of our case number 2, urodynamics, which we do in preparation often for transplant to make sure the bladder, check the compliance of the bladder. On him, he had a very low pressure bladder, no overactivity. He only filled to about 30 cc's, which is about half the capacity, as Ben mentioned. However, at that time, he generated a strong contraction. And you can see here, he only had reflux at the time of the strong contraction. So that might continue to evolve and resolve over time as bladder would grow. So the use of urodynamics in valves or in other bladder pathology is a little bit controversial. Some people truly believe in it, and some people feel like it's not always required, although I do think it's gaining, and we're using it more and more. It can be done as a baseline study. It can be done to assess the shape of the bladder. We can use it if you have the video component, which is the fluoroscopic component. You can use it in lieu of a VCUG to confirm complete valve ablation. And you can determine sort of the compliance and pressure of the system so you know down the line what you're heading for. It also can be done periodically over time as the child grows for any concerning changes. There's worsening hydronephrosis, urinary tract infections, or even later on with voiding dysfunction or incomplete emptying, you can really get a sense of what the cause of those changes are. And finally, and this is something again that has been used, especially in the adult setting, we're using it more and more, is pre-transplant evaluation. Even though we can transplant into small bladders, bladders that can be cycled up, you do want to know if it's a hostile bladder that you're transplanting into. And so this can evaluate for that. There are caveats, and and why some people are resistant to use urodynamics as much in valves is that a lot of these kids will have vesicoureteral reflux that can affect the bud's finding, and you have to take that into account, because if you have simultaneous upper and lower tract filling, you might actually be underestimating the bladder filling pressure, but still you can really determine the pressure of the entire system, and you'd be able to see if there's significant overactivity because the bladder would still be contracting and generating those pressures. You also can identify whether that reflux is occurring later in filling versus early. If it's early, again, it might be hard to just determine the exact bladder dynamics, but if it's later in filling, then you might be able to tell if the reflux is a result of higher bladder pressures, or if it's at low pressure and it's just late in filling that it's occurring.
So to summarize some take-home points from our second case, again, a 2-day-old that presented with eventual diagnosis of urethral stricture, went on to need peritoneal dialysis and then a kidney transplant. Respiratory complications are a common cause of morbidity and unfortunately mortality in neonates with congenital anomalies of the kidney and urinary tract, or CACIT. Getting input from both nephrology and urology with prenatal care is important, but additionally relying on your NICU team to help with the management of these patients early on, especially when a lot of them can have severe respiratory disease, ventilator, oscillator, etc. As Dana noted, congenital urethral stricture can be an imitator for posturethral valves, but also we talked about posturethral valves in general, and then considering video urodynamics or VUDs in the evaluation of the bladder, especially in preparation for transplant, to see how that they will do under various pressures after transplant. So we'll finish up with case number 3. So this is again a baby, now a 2-month-old, that gets evaluated by our center for a second opinion. The patient had a pretty extensive surgical history before coming to us at CHOP. At 2 weeks of age, underwent cystoscopy, had posturethral valves that were resected, had a left ureterostomy that was placed, and then creation of a vesicostomy and a circumcision, as Dana noted, which is common in these patients when they undergo surgery. Again, as noted with our other patient, testicular findings are common in these babies, so paying particular attention to those patients. This patient was noted to have bilateral non-palpable testes. The patient stayed with us for 1 month in the NICU after transfer, had a history of urinary tract infections. We haven't talked a lot about urinary tract infections, but certainly preventing infections with prophylaxis and educating families on what to look out for infections is very important, both as a way to try to keep as much residual renal function as possible, but also to obviously prevent the morbidity associated with frequent infections, them being in the hospital, antibiotic resistance, etc. The patient had a lower creatinine than our other 2 patients, 1.3 milligrams per deciliter, and was trending down. Mom was catheterizing the ureterostomy and the vesicostomy twice a day. At 6 months of age, on follow-up, the patient had revision of vesicostomy and implantation of the right ureter, concern for poor drainage, was continued on ditropan and now Keflex prophylaxis, and then needed to start peritoneal dialysis at 1 year of age due to failure to thrive and a rising creatinine, but unlike our other patients was less acute indications for dialysis with electrolyte findings, but more trouble growing was the indication for starting dialysis in this patient at 1 year of age.
Just as a brief interlude as far as the use of diversion in valves, in this case, it was done again for concern for urinary tract infections, and actually was revised due to concern for urinary tract infections because there seemed to be a lack of adequate drainage. But even though, as I mentioned earlier, that the sort of gold standard is, or the standard of care is valve ablation, a cutaneous vesicostomy can be used in valves just as well. It can be very good for temporizing the situation if the newborn is too small or too sick. usually to have a cystoscopy and valve ablation, as vesicostomies can even be done in the NICU if needed, if there's concern for infection with catheter. Also, if you just don't have the equipment of the very small cystoscopes, and vesicostomy can be done, and then a valve ablation done later on. As I mentioned, after the newborn period, sometimes if there's recurrent urinary tract infections, worsening upper tract dilation, and concern that the bladder is not emptying well in spite of clean intermittent catheterization, sometimes a vesicostomy can be created. And I think the main thing is that there's always been concern that it will defunctionalize the bladder long term, but we've actually found that not to be the case, and that the vesicostomies can be closed and the bladder can still continue to function. The use of upper tract diversion, and in this baby he had both, such as pilostomy and ureterostomy, hasn't been used as frequently in recent times, because it will require sort of still complex lower tract reconstruction rather than just closing a vesicostomy. However, it was more common before endoscopic instruments were available, and there was always concern that if a baby had persistent bilateral upper tract dilatation, that diverting the upper tracts would be beneficial for the renal function. However, over time, that was shown to really not have added benefit. And it does take the bladder out of commission completely, so we've tended to do that less often. And this baby had the left side diverted, the right side stayed in place. There was concern that the right side potentially wasn't draining as well, contributing to infections, and so a wide open anastomosis was created. I've been mentioning vesicostomy for the non-urologists who are listening, just to give a brief review of it. You open the bladder wall, usually about 1/3 down from the umbilicus to the pubic symphysis. You reveal the bladder, and this is all extraperitoneal. You peel that peritoneum off the posterior wall of the bladder, and you really want to get to the dome of the bladder at the level of the urachus, and that's where your incision is going to be, just at or just posterior to the urachus, as that will decrease your risk of prolapse of the vesicostomy. Then you're going to suture the detrusor to the surrounding fascia. One note also that we tend to do is in sensate boys, like in boys with valves, they have strong abdominal muscles that might actually prevent the vesicostomy from draining all the time. So you can incise the muscle on either side to help to make sure you have a wide open and draining vesicostomy. And then you mature the detrusor to the skin edge, and you could see how it had healed in that other picture. As I mentioned, there's been concern always for ureteral dilatation that persists after valve ablation or even after vesicostomy. Really, the indications for surgical intervention are recurrent urinary tract infections. Generally, if you haven't done yet, you do a circumcision and you can leave the child in prophylaxis. Again, if there's very concern that the ureter isn't draining, then in rare cases, you can do a ureteral reimplantation to make a wide open connection to the bladder. Now, this is the word of caution that if it's dilation due to reflux, we do caution against reimplantation for reflux, as that might actually, one, impair your renal drainage, which is going to hurt your overall kidney function, has a higher complication rate, one, for strictures, and two, you have a very high chance of persistent reflux, because reflux in the valve bladder is usually due to the bladder and not a matter of the UVJ, the ureterovesical junction. And so you can fix reflux and it'll just keep on coming back until you ensure that the bladder is working and draining properly under low pressures. Back to you, Ben.
To summarize our third case, so at 3 years of age, the patient developed an exit site infection requiring removal of his peritoneal dialysis catheter and unfortunately conversion to hemodialysis, which, as I mentioned, is more challenging in these young kids, although by 3 years of age, dialysis is certainly more feasible and less challenging than at 3 months of age. At 4 years of age, this patient, similar to our other two, had surgery to repair his testicle, so right-sided second-stage orchiopexy, and then eventually received a deceased donor transplant with his ureter attached to his bladder via the vesicostomy, and similar to our other two patients, is doing well with a last serum creatinine normal at 0.3 milligrams per deciliter. And so to finish up in the last few slides, Dana is going to take us through a little bit about the data on transplanting patients into urinary diversions and using this case as an example.
So, we've discussed earlier the concerns about transplanting to a small bladder, and then, as Ben mentioned, there's always been concerns about transplanting into a vesicostomy. Historically, there was concern regarding risk of infection. And so, again, in a lot of centers, patients would undergo augmentation cystoplasty to avoid transplanting to a vesicostomy. Of course, at least in my mind, an augmentation has a higher risk of infection, not to mention stones and obstruction, mucus, and more severe consequences. So because transplants are being done at younger and younger ages, as we've just gone through these cases, and Ben has highlighted the need for dialysis at extremely young ages and transplant at young ages, continent diversions might be very difficult at these young ages, and a vesicostomy is much easier to take care for. They have a low risk of infection if they're freely draining, and they can easily manage the high volume output of an adult kidney that might be placed. So in 2013, a group had looked at results of transplanting into a vesicostomy. Out of 80 patients with renal dysplasia or obstructive uropathy and 43 who had data available, 7 had obstructive uropathy and were diverted, 5 with a vesicostomy and 2 with cutaneous ureterostomy, compared to 16 who were not diverted and had just had obstructive uropathy and 3 who were augmented. And the findings were, while there might have been more UTIs in those who were diverted, it was not really different than those who were augmented. The GFRs were the same, and there was no evidence of graft loss in those who were transplanted into the vesicostomy. The one graft loss that occurred in the obstructive uropathy patient with no diversion was due to noncompliance with the medications. Another small series more recently also had just 5 patients. Again, all these are very small series with very small bladders and poorly compliant bladders. They were all transplanted into a vesicostomy because of these poorly compliant bladders. There have been 2 out of 3 have had infections, but 3 have done very well and haven't needed a significant surgery since then. One needed a revision of the vesicostomy, but the other one had cutaneous ureterostomies as well as the vesicostomy, so did not need any further surgery.
Take-home points from our third case. Early diversion is often necessary to optimize drainage, prevent infections, and maximize renal potential. Unfortunately, in some of our patients, despite diversion, they still need dialysis and a transplant. But it's important to try to prevent infections both in the pre-transplant period and also to set up their bladder and urinary drainage for success after transplant, when we want to, of course, protect the graft long-term as long as possible. Transplant into a free-flowing vesicostomy is safe, so hopefully avoiding bladder reconstruction in a lot of these patients. And patients may require reconstruction once transplant function is confirmed and the child is ready. So in summary, to finish up, we left a few minutes at the end for questions and discussions. After going through our 3 cases of young children needing dialysis and early transplants and different management of their bladders. Non-surgical management can include bladder cycling, as Dana noted with SP tube placement. Video urodynamics is an important study in the evaluation of patients' bladder, especially those getting ready for transplant. In some patients, surgical management, including diversion, vesicostomy is needed, but again, hopefully trying to avoid bladder augmentation. And then we will finish up, and please let us know if you have any questions.
Thank you so much, Dr. Laskin and Dr. Weiss. So just a reminder for our audience, there's a Q&A button on the right-hand side. You can use that to type in any of your questions, and we will read them and address them. While we're waiting, I have one question just to kick things off. If you were going to provide some recommendations to another institution that wanted to sort of improve collaboration between their urological team and their nephrology team, are there any kind of key insights you would give in terms of how your 2 divisions have collaborated?
So I'll answer first, and then I'll let Dana give her perspective. So number one, and the easiest thing is geography. So both of our clinics are located now in our new clinical building on the same floor. So it's really easy to have patients see us both on the same day. Oftentimes one of us will be in clinic and the patients have an acute issue that comes up. Just last week, one of our transplant patients had a pretty significant testicular issue, and I went down the hall and grabbed a urologist, and they saw him in about 30 seconds, which I told mom was the fastest consult that I'd ever seen. So I think geography is important in making sure that patients can move back and forth and we can move back and forth, and our clinics are literally right next to each other. I think from a more programmatic standpoint, in the last few years, we've really started to work together more in the NICU. And so we've had a monthly meeting with the neonatologist where we discuss patients that have been seen prenatally by both groups, and including the NICU, as we mentioned, in the patients that have concern for pulmonary disease due to oligohydramnios. And so having those meetings and all of us be there, I don't know, we call them working group NICU meetings or NICU kind of collaborative meetings where we have representation from not only urology, nephrology, and the NICU, but also the special delivery unit and maternal fetal medicine, and including surgery and even interventional radiology for the patients that need access after they're born. So I think that kind of standardized approach and frequent meetings, so both geography being close to each other and frequency, having meetings on the calendar where we all come together once a month to discuss cases. And then the last plug I'll put in before letting Dana talk is, Dana has now been coming to a lot of our transplant meetings in the pre-transplant patients so that they get to know them early on, having kind of a lower threshold for patients being evaluated by urology for transplant. So making sure you ask about constipation, making sure you ask about nocturnal enuresis, things like that that may give a hint that there's bladder disease that needs to be evaluated before transplant, so the surgeons don't get in there and see a big floppy bladder or a small constricted bladder that we didn't know about. In the kids with valves or obstructive uropathy, of course, they're seeing urology, but kind of having that input early on in the pre-transplant meetings and the evaluation meetings, I think, has been very helpful.
Oh, for sure. I really have very little to add. I think just avoiding the silos that I think medicine can turn into, and having this open communication. Also having it is nice to have a point person that you say, all right, any transplant issue anyone has, or I'm going to contact Ben or Sandy, or having those meetings so everyone knows each other, and it makes it a very free-flowing communication. And I can't echo enough, the idea of the geography of being able to go down the hall and just ask the question or discuss a patient. Just yesterday with patient number 3, I talked to his transplant nephrologist and went and saw him all within probably 50 feet. And that really aids in the collaboration.
Okay, great. It looks like we have a couple of questions in the Q&A queue, so I will start with one for either one of you to answer. And the question is, what do you do with the vesicostomy as the patient gets older? Closed with urethral cath channel, are they continent enough?
No, that's a great question, and I think it's very patient dependent. Most of them will end up getting closed, depending on if you can sort of assess whether they'll be able to void. You can close them and see how that convert them to a suprapubic tube, see how they void. If they don't, then create a catheterizable channel. Some people might advocate just creating a catheterizable channel right up front, because that way you have it in there and you can help them, because a lot of boys with valves will ultimately end up with failure to empty, sort of power failure of the bladder, and so they might need the cath channel. But they don't end up staying with a vesicostomy, although historically there were some patients who did, but most of them will get diverted in some way or undiverted in some way, either straight closure and they can void, or closure and a cath channel.
Okay, great. Thank you. Our next question is, are children with a bladder cycling doing this 24 hours per day for 3 to 8 months, or is this something that is intermittent? would this be something that can be done weekly or in a more intermittent way for less compliant families?
So it's not quite full 24 hours, but it's as close to as possible. And I do think it takes the sort of the buy-in from the families as far as whether it could be done more intermittently. I'm sure it could, as long as the suprapubic tube stays in place, because you wouldn't want to have to go and put it in, take it out, put it in. But even if they're doing it for several hours a day or even just at nighttime, I believe it would be beneficial. Just sort of we do overnight drainage to decompress the bladder for patients with neurogenic bladder. If you had overnight cycling, that would probably provide some element of cycling, even if they wanted to do it just at nighttime. And we haven't figured out yet sort of what's the exact duration that's needed, what's the best time, what volume is then they're going to be set for post-transplant. I think there's still a lot to study there and to learn about, but I think that you probably could figure out some sort of intermittent schedule.
Okay, great. Thank you. Are there other questions out there? I don't see any other in the queue at this moment. Okay, well, I think then we can bring this session to an end. Thank you very much, Dr. Weiss and Dr. Laskin. This was a great presentation and we appreciate the time. Thank you. Thank you everybody for joining us today.
Thanks everyone for joining. Have a good day.
Thank you.